Hi, and welcome back to the Robbins Headache Clinic YouTube channel. We're putting a series of talks and lectures about headache-related subjects. We've done refractory, difficult-to-treat headaches, psychological comorbidities, and this latest talk is what I call Deconstructing the Art of Headache Medicine. I'm trying to deconstruct what goes on in our initial history with a person and with return visits, how we choose one therapy versus another. I've given this talk to headache societies, I've given this talk to neurology residents, and at the end of a visit, we end up with a top 10 list for one person versus another, and it's different from everybody. There's really no good algorithm that you can throw into a computer and say, this is the best way to treat this headache person, this is the best way to treat that one. If you have 100 different people with headaches, you end up with 100 different ways to go. As I used to say, if you know one headache person, you know one headache person. Everybody is unique. So how, at the end, do we decide out of our brain computer that this is the best treatment? And the following talk will help to enlighten this process and help you possibly with your doctor in choosing the best medicine. So first is age. We treat headaches differently at different ages. If somebody is 16 years old, we're going to treat them differently than at 26. We'll treat them much differently than people who are 56 or 86. And it's interesting, headaches in the elderly haven't had enough written about them. We treat headaches after age 75, 80 much differently. There's a lot of the medicines that you can't use. We don't want to give them medicines that are going to create ulcers or kill their kidneys. Of course, the definition of elderly changes. I wrote a book on headaches. It was about 25 years ago, and in my early 30s, my definition of elderly was after age 55. Then I wrote a book about 10 years ago. My definition was moved up. Now we have a new book out, and my definition of the elderly is after 75 or 80. So as I get older, my definition goes up. But age is a big factor. How the headaches came about is very important. We treat new onset daily persistent headache, NDPH, it's called, and that's an entity that you can look up, much differently than the regular daily headaches or frequent headaches that come about, where it's called transformed migraine. People have more and more headaches starting in their teens. They'll have one or two headaches a month. Then by age 20, they'll have one or two a week. And then by age 25 or 30, almost daily or daily headaches. And that's what we see a lot in our office, our clinic. So how the headaches came about affects how we treat the headaches. Transformed migraine, which come about slowly, tends to be more amenable, more treatable with daily preventive medicine or Botox. The NDPH is tougher, where people just wake up or within 24 or 48 hours they have headaches, or post-traumatic headaches, where they have headaches from getting tackled in football or rear-end collision or falling and cracking their head. Those are tougher to treat. Severe neurologic deficits affect how we go. If people have numbness and weakness on one side of their body with their headache that lasts more than minutes or half an hour, we might treat it differently. If people have an aura, which is your typical flashing lights or difference in blurry vision or a little tingling in their arm, we may treat it slightly differently. And it affects where we stand with birth control pills and other factors in the headaches. Where the pain is will affect our therapy. We might, if people have just pain in the back of their head or 90%, we may recommend injections there or some physical therapy. About half the people with headaches have neck pain or pain in the back of their head primarily. So physical therapy, injections, massage may help. If it's just in the front, in the sinus area, most sinus headaches are just migraine actually. About 96% of people with headaches have sinus headaches have migraine. They're just diagnosed as sinus headaches, but it's actually migraine just hurting in the front. So if it's in the front, we may treat it differently. We may do Botox or SPG blocks where we squirt Novocaine up the nose. Mild daily headaches versus severe migraines. Many people have daily headaches and migraines. And the issue is, which one are we going to go after? Are we going to treat more of the severe migraines, or are we going to treat the mild daily headaches? And of course, it's which one the patient is more concerned about. So we ask people, what bothers you more? And it might be equal, it might be both, but many people say, oh, it's the severe migraines that happen every 2 weeks. It's horrible, I can't stand it. It's these daily headaches I'm used to, and I take care of them with 2 Advil. Other people say, the migraines I have taken care of, I take some sumatriptan, it's really these daily headaches. So which headache type to go after is very important. How quickly the headaches become severe is crucial. If the headache meanders along for an hour or 2 or 3, we have more time with tablets. If it's an explosive onset, people wake up with our headache, or it's severe within 10 or 20 minutes, we might need a nasal spray or even an injection, or occasionally a suppository. But how quickly the headaches become severe does drive therapy also. We look at triggers for headaches. Weather, stress, hormones tend to be the top 3 triggers. And this is important. Sometimes many of the triggers we can't do that much about. We can't change the weather. But it does help explain. A lot of people say, well, I can change the weather with I can predict the weather with my head. I can tell when a front's coming in. And it's true. They're a barometer. Some people do move across country for their headaches to San Diego or Arizona or Hawaii, where weather is more steady, but it doesn't seem to matter that much. Usually, they do have headache clinics in those areas also. Menstrual migraine we may treat a little differently and using some medicine right before and during the menstrual period. And so menstrual migraine is, it's important to know how severe they are. We might be able to time medication. Headaches, stress is a trigger for many people. Some people have their inherited stresses, their inherent stresses that they can't change that much. But we work on stress management quite a bit. Exercise, meditation. We work at trying to get people into a psychotherapist sometimes. People don't go to therapists, psychotherapists, because generally of money is an issue or time is an issue or both. But it often does help. But we want to find somebody in the top 10% of therapy. Therapists are like doctors or lawyers or accountants. It's a bell-shaped curve. You have the bottom 10%, most are average. You want somebody in the top 10% of therapy. Now we look at previous medications, what worked, what didn't work, and side effects. Previous medications that the person has taken guides where we go very often. We don't want to continue mistakes. If people had problems from antidepressants, we may not want to pursue that or use different ones. If they had severe tiredness and weight gain from a beta blocker like Inderol, we don't want to just use another beta blocker. Side effects and sensitivities need to be in our chart very readily available. A lot of doctors and healthcare providers make the mistake of putting people continuously on medicines that they've had a lot of side effects or been sensitive to, because it's not easily available to them, this information. It has to be in the chart. With electronic medical records, it's not so easy always. It's actually easier on old-time paper charts to keep track. Over-the-counters, we want to ask about Advil, Aleve, Excedrin. Did they help? Did they have side effects? We don't often want to change everything when somebody comes in. So if Advil is working and people are not using too much, we may want to continue the Advil. We don't want to just say, well, stop everything you're taking and we're going to start from zero. It gets confusing for people to throw all this new medicine at them. We want to go over vitamins and supplements. I like to get everybody on vitamin D. I've been a big proponent of vitamin D for 13 years. The last 100 studies, 97 of them are positive for D. but you can't say that about other vitamins. Multivitamins have issues. There's problems such as increasing cancer rates, and the same with A, C, and E. The antioxidants A, C, and E, vitamin A, vitamin C, vitamin E, really should only be taken in special circumstances, and 99% of people who take these should not be taking them. So I've been saying just take your D and try to get enough calcium. We talk a lot about calcium. But outside of that, you can get omega-3s naturally with flaxseed, with eating fish, with eating nuts. And there's no evidence that taking omega-3 capsules really helps the heart or stroke or anything particularly. Medication overuse we look at. Is it a problem? Are people taking 6-Excedrin? Medication overuse headache is often confused with medication overuse. Medication overuse is arbitrarily defined by the powers that be as 10 or more days of a certain type of medicine, such as an opioid or barbiturate or triptan, or 15 more days a month of any sort of analgesic, including Advil or Aleve or Excedrin. But it is arbitrary medication overuse, those number of days. What's more important is determining, is the person having headaches from the medicine? And that's difficult to do. So the epidemiologic studies showing so many people have medication overuse headache, and they've done these studies looking at 100,000 people with surveys, they really aren't all that valid because each person, you need to take their history, what happened when they went on the drug, did their headaches get worse, and then what happened when you took them off of the drug, which is not so easy. So determining medication overuse headache is important, but it's not an easy task. Did they have Botox or other procedures like SPG blocks up the nose, occipital blocks, trigger point injections? Has the person had physical therapy, massage? What have people had? Has it helped? We need to go over this whole history. Now, outside of medicine, we do a lot. It takes a village to raise a severe pain patient, and we get other villagers involved. So we get physical therapy, we get psychotherapy. Occasionally we'll go along with chiropractic, acupuncture sometimes helps, meditation, biofeedback. We're always pushing exercise. I'm trying to get people to average 20 minutes a day of exercise, and little bits of exercise often do work. 5 minutes, 10 minutes, we have them using a step counter or a Fitbit on their wrist. I like the Garmin VivoFit because the battery lasts a year and a half. You don't have to keep recharging the Garmin. A lot of people put their Fitbit in the computer and then forget about it. It's difficult to reapply. So I like the Garmins, but any sort of step counter can help. Stationary bikes are good. We push stationary bikes because they're the most used piece of equipment. The treadmills and ellipticals often just become fancy clothes hangers. So I like stationary bikes, watching TV and putting a laptop in your stationary bike, shopping for a bike where you can put a computer or read a newspaper. Of course, under age 40, I explain to people what a newspaper is. You know, it's one of those things you fold out and it has print on it. But stationary bikes are really good to have in front of the TV. We look at current medicines. What's helping, what's not helping, over-the-counters, what's helping, what's not helping. The current medicines, the meds people have taken in the past, this guides us very strongly towards our medicine choices. Common headache situations I mentioned, like menstrual, but there's others. Flying, many people get airplane flying headaches, so we might use something early, right before the plane ride or in the early part of it if it's a long ride. Altitude, we can use medicine for altitude headaches and exertional headaches. If people have exercise-induced headaches, we might use something right before the exercise, such as naproxen, Aleve, or indomethacin. So these special headache situations are important to know about. Prolonged headache, is the person having long headaches that go on for days? We might treat them differently. Sometimes we use cortisone or prednisone, something special for the long headaches. And is the person having what we consider refractory headaches? In another talk, in 2 parts on this channel, we have a talk on refractory, difficult to treat headaches, and we also put the slides up. Whether people are having refractory headaches depends upon, have they done okay with daily preventives. If they haven't done well with 3, 4, 5, 6, 10 preventives, we consider them more difficult to treat or refractory. And we take a different approach to refractory headaches. So determining whether somebody is difficult to treat is important. In the emergency room, we want to know what's worked, what's not worked, have injections of ketorolac or Benadryl or Reglan help, DHE or opioids. And if we have that information, we might be able to get the same medicine or similar in a milder form sometimes to people to try at home to avoid going to the emergency room. We always try to avoid the ER because they're loud, they're expensive, it's inconvenient, and people don't make it to the ER until 4 hours, 6 hours, 10 hours into the migraine. So we want them to have things at home that they can take care of their migraine. Now, patient preferences are very crucial. Do people want natural remedies? Do they not want suppositories or nasal sprays or injections? If people don't want any sort of injection, our SPG blocks or occipital blocks or sumatriptan shots at home, we won't go there. If people don't want nasal sprays, we cross that off the list. So what people want, they are a full partner with us in what they are going to take. Patient preferences, it's not 1980 where we had more of a paternalistic model of medicine where a patient sat there, said their spiel, I asked them a few questions, and then I said, this is what you're going to do, and they didn't ask questions. It's really more of a partnership now. And people are much better informed. They use Dr. Google all the time and are all over the internet. The internet is 80% good, 20% not so good, but overall, it helps. People know a lot more about their condition, about the medicines, and it helps us as healthcare providers. Family history, too, is very important. Response to medicines. If a mom comes in with her 18-year-old daughter, and the 18-year-old daughter is the patient, and I mention the medicine Topamax, and the mom says, oh my God, I crashed my car on Topamax, it's the worst medicine in the history of the world, well, I'm not going to give her daughter the Topamax. It's called the nocebo effect. That negative influence or just statement from the mom is going to make it more likely that Topamax won't work. Plus, there's genetic factors. What works for mom genetically might work for daughter. The same goes the other way. Sometimes a 50-year-old man will come in and say, I think I have ADHD, ADD, and I say, why? He says, because my son was diagnosed with it and is on Adderall and doing very well. So a lot of things run genetically, and we look at response to medicine genetically. On the other hand, there's a placebo response too genetically. If that mom comes in and I say to the 18-year-old daughter about Topamax, and mom says, that was the greatest medicine in the history of the world, I lost weight on it, it was 90% effective for my headaches, that may be better for the daughter. So we look at family history of response to medicines. Psychiatric comorbidities, we pay a lot of attention to. If there's anxiety and depression, personality disorder characteristics, bipolar characteristics, if the patient has anxiety or depression or long history of depression, we're always on the lookout for mild bipolarity, mild end of the bipolar spectrum. And we did another talk on this channel on the bipolar spectrum, really focusing on the mild end of the spectrum. We look at anxiety and ADHD, and that may influence our treatment. Reaction to antidepressants, we're very keen on. If people took Prozac or Zoloft or Paxil and were up all night, wired, we may think of the mild end of the bipolar spectrum, and we'll certainly avoid antidepressants. And the response to other psychiatric meds is very important. And their family history, their mom, their dad, their brother's response to the psychological medicines is crucial as far as where we'll go with medicine. Family history of psych is very important. Is there a bipolar spectrum in the family? Is there suicide, severe drug abuse, institutionalization? Is there a parent or a brother with a personality disorder? Substance abuse is crucial to look at. Addiction history. If there's a strong addiction history, we may avoid anything that could possibly be addicting, possibly. Is there a history of anxiety in the family? Anxiety is very genetic. You can trace it in 4 generations. Anxiety is a very physical illness, as are all of these psychological comorbidities. At age 5, you can look at the amygdala, which is part of the limbic system in the brain. You can image it in certain ways and predict almost who has anxiety. It's bigger, it fires constantly. So these psychological comorbidities are not in your head or psychiatric purely. They're really just as medical as having asthma or diabetes or high blood pressure. We look at a family history of response to the psychiatric medicines. That's very important. And we assess for abuse as a child. Physical, emotional, sexual abuse as a child translates into stress, which translates into serotonin and other chemical changes in the brain that may be permanent. So people with severe pain that's unremitting, fibromyalgia, we call these central sensitization syndromes, chronic pelvic pain, TMJ, chronic headaches, may have had an increased chance for abuse as a child, and abuse as a child also leads sometimes later on to more likely to have depression, to have personality disorder. So we look at significant abuse. Did they have more than mild abuse? And what we'll do is push people towards psychotherapy. We might use certain antidepressants or mood stabilizers, etc., but it's helpful to know about. Wrap it up here, and we're going to be putting more talks on, headache-related talks. Thank you very much.